Hey guys, Don here. Welcome to Podiatry Practice Mastery. This is the end of day 3 at the practice AAPPM meeting. And I want to thank all those that listened to this last number of episodes. I tell you, my brain is tired. I'm just getting back into Massachusetts here, and I want to just finish up this last day so I can post this and then be done. But it was a really good conference. My brain hurts. I like most of these conferences. I liked the lectures, but I get a lot out of the conversations with people between the lectures. That's what one of the best things is. There's another one coming up in December that is for Shockwave, and I'm going to be going to that one. So if anyone else wants to go to that one, that'll be Boston. That should be good. Talk about a few things. First, my biggest embarrassing moment. I just want to share this with everyone. Is that they're talking a lot about exact numbers and knowing your break-even point and knowing a lot of these things. Now, we get our numbers about every 6 to 12 months. We go over those. We're not super duper in depth, so I feel like that's some area that I could improve on. Would be running a little bit more numbers, and I tried to create a few calculators in Excel. So if anyone wants to look at them, underneath this podcast, you'll see a link not just to the calculator but also to all the notes from the AAPPM meeting. Okay, so a couple of things I just wanted to share. If I haven't mentioned it before, my favorite podcast, if you'd like to follow anyone else besides my podcast, is Alex Hamosi. He's got a podcast called The Game. It's very, very good. I also wanted to say that he helps people get their business to the $5 million mark, and then he invests in them as a venture capitalist. So I like the idea of them helping and then investing in it. And that's very similar. What I was talking to the people over at Lexington Podiatry, I think they do a great job. And one of the things that they're doing is they're having this internship, almost like a fellowship. And if they stay for a couple years, and then they say, well, you can either join us if you're good, or you could open up your own and we'll help you with that. So I kind of like that. They're almost like investing in their practice with them, which I think is a really good model. Today, some of the lectures, one was on in-office surgery. I like that. I do in-office surgery. I do flexor tenotomies. I do exostectomies. I don't do bony arthroplasties, which I think I might start doing. I don't have to do a lot of plantar fasciotomies, but that would be something that would be easier to do. But I don't have the burr type of thing, the burr shaving down things. But we do have a surgical suite, and we do those more. And I like the idea of picking up more of those. Maybe not the MIS stuff, just because I don't focus too much on that. The art of having your cake and eating it too. I thought this was really good. This was a really good lecture. This is by the Lexington Podiatry, and once again, I'm just I'm inspired by them. They do great work. One thing they did is they ran their numbers, and they found that 15% of their profits were from OTC things like shoes, pads, creams, and then 27% were like ancillaries, which is like laser. I don't think they have Shockwave, but it would be Shockwave, orthotics, ABIs, DME, amniotics, things like that. And then I was kind of thinking to myself, well, if I wanted to be more like them, how could I optimize? And I think it's optimizing and doing protocols. That's what they do. I have talked to Nicole. That's what she does. She does protocols for everything that she does. If it's not in a protocol, you're not going to use it. And I found the best thing that helps are the patient presentations and the treatment sheets. If you don't know what those are, send me an email and I'll help you. Done at podiatrypracticemastery.com. I have all of those for anyone. They also found that nail care was 33% of the patients, and it was bringing in 3% of the revenue. So they found a neighboring podiatrist, and they sent it to them. They started to treat them for a couple months and then sent them over to another location. And I like that idea because some doctors like to treat routine care. But to do that, you have to calculate what are the profits from routine care. Now, I want to confess this is something I didn't really know how to do, but I asked ChatGPT, and I'm kind of learning. You have to look at what your fixed costs are, and then you divide that by your revenue gained minus your variable costs. So basically, if your revenue gained is only a little bit above the cost, and then the fixed and variable are kind of equal, then it's like a wash to do it. So you really want to have a good profit margin on what we do. And I was thinking what would really help me is to figure out an actual cost per treatment room. So let's say in both of my offices I have 6 treatment rooms. I'm open 8 hours a day. How much is it just to have that office open and staffed for that treatment room per hour? So that really makes me think again what type of procedures that I'm going to be putting into that treatment room. I don't know if anyone else does that. I'd love to know how you do that. I'm still kind of learning it. ChatGPT is helping me. As I'll learn, I'll share it with you. Offloading patients, they said that was one of the most challenging things, and they had to explain why they didn't see nail care, and it's not because we don't like you or love you, it's because we want to be more available for other conditions that we want to see. So I thought that was kind of an interesting thing. They had, in their lecture, they talked about your ideal patient, your ideal avatar, and then doing an ICD analysis. This is something I didn't think of before. I really like this idea. So basically you take your diagnosis codes and you put them into buckets. So what percentage are you seeing of wound care, of surgery, of general podiatry, of aesthetics, of preventative medicine, of biomechanics? And then if you put them into those categories, you can figure out what you like to see and then what's most profitable. And then once you find the most profitable ones or the largest checks, those are the ones that you're going to focus on investing more marketing money to those ones. They also talked about a few categories. You're going to have to look at my notes to see how this works, but the patient lifetime value is found by the total expected revenue that the patient is going to produce in their whole life. So the average per visit value times the estimated number of visits. And we would have to figure this out. I just kind of, when I was doing my calculations, I guessed at 4. The patient acquisition cost is the total marketing cost divided by the total number of new patients. This is a new number to me. I wasn't familiar with this. I kind of put my marketing costs into my variable costs, but I like the idea of separating out variable costs from marketing to directly relate to new patient visits. I like that idea. And then the break-even point. This is something that I was playing around with when I made a spreadsheet. I was thinking about how many shockwaves would I have to do to break even on the monthly payment, or Swifts, or whatever else. And those are going to all be in the templates if you want them. The link is going to be underneath this podcast. But to do the break-even, you have to, which I talked about before, you can break even for anything. It's even like breaking even for having your half day of routine care. So that's something you could figure out. So you can kind of look at my break even and my templates, everything here. Then they recommended taking this and then making it into a dashboard. So that's a kind of a visual dashboard with something called your KPI, which are key performance indicators. I want to confess I'm not the best at this. I want to learn how to do this. I think this is great, and I think once it's set up, it can be really easy to do. Cody was talking about he just needs 3 numbers from the EMR, and then it forecasts everything, and I'm thinking that's great. What are those 3 numbers? He didn't tell me. Maybe he will, and if he tells me, I'm going to tell you guys. And then they also recommended doing a referral analysis, who's sending you what patients, helping teach educate the referral sources, and more importantly, those referral sources that are sending you more patients that are more valuable, investing more in them. And we have this we can do in Athena, where I can see who has referred and how much it's generated in value. It basically, I look at the referring physician for patients, and I can look that up, and I can invest in the top 20 of those and educate and try to wow them. So they found that the more new patients, I think we all know this, the more new patients, the more profits. Now, Nicole, she touts a number of a little over $1,000 for charges per visit. And I was thinking that's how she can only practice 1 day a week. Because if you think about it, let's say you're seeing even 25 patients in 1 day, that's $25,000 in charges. But I don't think it's just charges. What I think it is she's selling packages of laser, and then someone else is doing that. She's doing DME, for AFO. She's doing a lot of other things, orthotics. And so all of that in those visits, and then all of the follow-up is done with a nurse practitioner. I just think it's a great model that's working for them, and they're just a 2-doctor practice. So kind of creating these treatment plans and then offloading them to other people. There was a nice lecture. I'm not going to go too much into detail on modifiers. You can look at my notes on when to specifically use the modifiers. I confess, I think my office biller adds these to them, and she might not be adding them, but she probably should be, so I'm going to try to give her these notes to see if she knows about them. And then there was a separate lecture on 25 modifiers, which was kind of interesting. I think we all use them. But one thing I wasn't familiar with, that Luke was talking about, there are certain numbers, every procedure has a built-in E&M to it, let's say 5 minutes of discussion and management. And when you go over that, you can do a time-based office visit in E&M. I don't know too much about that, but I'm still kind of figuring that out. And so when they come in, for example, for a cortisone injection, and they have a lot of other questions about other things, you can get paid for an E&M because you have been spending more time with them. I thought that was kind of an interesting idea. It's something that I'm not doing it so much based on time right now, but you can document. And he had this cool template, and I'm going to include this as well. You can see it. It says time preparing for the patient. I spent documenting the encounter. This is not calculated, including the pre-evaluated time inherent to the procedure code. So he actually has that in there. And then you just check the boxes. You don't say how much time you did in each one, but if you reviewed the diagnostic testing and blood work, if you reviewed their history, if you spent time with them discussing and ordering other types of things. So all that is in there. I'm not going to read everything off. Then there was a little lecture that talked about ancillary services. I'm a big advocate of those, like digital x-rays, ABIs. They have something that's interesting. They use a Podiatry, which I thought was a neat idea, to do all the AFOs and orthotic dispensing. I do the orthotic dispensing because that's when I bill it. I do not bill an orthotic dispensing. We just have them pick it up, and then I see them back and I do an office visit. But that was a neat idea. We talked about collagen, in-office surgical suite, doing diabetic shoes, in-office dispensing, all these things that we've talked a lot about before. Then there was a little bit of a conversation in the side about these new CBD creams, and there was one, I've been really against this for the longest time. I have BioFreeze. I don't really use it. And I'm do I really want something else I'm not going to use? That's what I was thinking. I was talking to one of the other docs, and he was a big advocate of it. He uses one that's CBD and has CBG, which is the baby plant version. I guess you could equate it to almost like my stem cells, as in mid-40s, versus a baby stem cell, or right from the umbilical cord. And that's what they talked about that. And then also how it has a special formula, because they have a product that for the nails that can absorb the antifungal into the nails, so it can use the same absorbent to go into the skin. I thought that was a neat idea. They gave me some. I'm going to be trying it out. I'll let you know what I think. They also gave a really great analogy. I don't know if I shared this with you before, but the analogy was the following. If a patient has an infection and you know that they won't take the antibiotic, are you still not going to give them the antibiotic? No, you have to give them the antibiotic. You have to do what's right for them because that's your duty. And that was in the same method as we were talking about other types of things, such as compression garments, to help with lymphedema, or other types of things that we recommend for the patient, even though an AFO, sometimes they might not use them, but it's kind of within our medical, our right, or our duty to do what's best for them. And then I was really impressed there. I don't know if you know a friend of mine, Lou DeCaro. He lectures a lot for the peds. His business partner is Roberta, and they have a orthotic company. Now, she's not looking for orthotics, but what I really admire about her and Lou is Lou, every 3 weeks, they do about 25 to 30 orthotics in a clinic. They have a clinic where they meet every 3 weeks, and she goes there, and they just watch them walk, video them walk, then cast their feet, and they do about 30 custom orthotics. Roberta on her own does about, I think she said 40 to 60 orthotics per, if I'm not mistaken, per month. That's great. And she does video analysis and a whole biomechanical exam and stuff like that. I don't really know many people that do that many, and she's a physical therapist, not even a podiatrist. So those are some kind of neat ideas. I'm inspired. I feel a little humbled because I'm not doing that many, but it's nice to see other people that are doing them. And then I had some conversations with some people that are even on my list, and there's one doctor that I was talking to that he's not even getting to $800,000, and he's seeing like 25 patients a day, and he can't even see more patients. And so I was having a discussion with him, and I'm trying to help out. This is like who I'm trying to help. Those are trying to get to the $1 million mark, and they're super busy and they're burnt out, and I'm working on this. This is the part that I was thinking the best way was probably to have him come and shadow me in the office. So if you guys are interested in coming to shadow me, just let me know. Shoot me an email, don@podiatrypracticemastery.com. I'd love to have you come and shadow. Maybe I can help you out more that way, but I give him some recommendations of maybe getting off of Medicaid or having like a routine block, and then doing more high-profit treatments and things like that for his practice. And then there are some breakfast ideas about like getting a new associate through this fellowship or this apprentice program that I talked about, and the EMR, inputting the value and using these numbers to determine what's the most valuable thing for your practice. So those are some things I've talked about as well. And then finally, we talked a little bit about coding and billing, requesting fee schedules, audits, a lot of things like this. I have to confess, it's not an area that gives me a lot of joy and interest. I like more of the marketing stuff, but it's something that we have to do. There was some ideas on recalling patients, especially like using a scribe to do that, or not a scribe, a virtual assistant that could do that like every 3 months and having them track that. They could also call back orthotics and AFOs. And then finally, the other lecture there was on routine foot care, which I kind of liked that because she's doing exactly the same thing I did. She has a half day that she does it, and I do half day on Fridays, and it's the best thing I ever did. I double book all the patients. It's only a half day. I'm able to make it more profitable, but there's no time for anything else, because if you only open to routine all the time, if you're too available, like is going to breed like. So I kind of like that method, and she kind of agreed with me, so I'm happy. I feel like I'm doing something right when it comes to routine care. So that's how you can make it profitable, I think. And those are kind of the takeaways from this meeting. If you want to see all of my notes, you can. There's some other things about like custom braces and stuff like that I didn't get to. Those were all from day 3. Okay? Once again, thanks for listening. This was a lot of stuff. I'm going to put this all in the Practice Mastery Academy, so if you're part of that, you don't have to watch these podcasts. They'll all be right in there together with the slides and everything else. But if you're not part of it, you can just look at my slides underneath this podcast and some of the other ones. My lecture links are in there as well. Hope you enjoyed those. Okay, thanks guys.